Hi, everybody. Thanks for being here. We appreciate it on this kind of yucky night. So, welcome. My name is Dana Vieta, and I'm an Otterbein alumna from the class of 1996. I was not a medical pre-med student. I was a comm student, so I don't know the world that you all are all likely in, but I do remember being a student here and having a wonderful time and having opportunities to interface with our alumni, which are important because they help to get you connections. They help to inform you on what it's like after graduation. And I work for the alumni office now. So this is part of what I do. And I want to point out my counterpart there, Mary Beth Metz, behind you all. She also works in the alumni and family office. So we hope to do more of these in the future to be able to put you all in contact with our alumni so that you can network, meet new people, find ways to get out after you graduate and just build your web of people that you know that you can trust because they all went to Otterbein. So we're happy you're here. We also have some guests with us on Zoom. Hi, Zoom folks. We see you. Hopefully you can see us. I'll zoom in a little bit more on the camera so you can see us better once I get back over to the kiosk. So with that, couple housekeeping things. If you didn't check in when you got here, if you wouldn't mind before you leave tonight, make sure you check in so that we know that you were here. If you need to step out and use the restroom or go get more pizza, that's fine by me. I don't think anybody would mind. If you need to go get some more food, please feel free to do that. And, I think we'll go probably for about an hour. And then if everybody, has a couple minutes to stay after, if you want to come up and meet our panelists, and I think that would be great. And I guess with that, I will tap off to you, Dr. Tanzi. Thank you for doing this as our moderator.
Hi, everyone. Good evening. It's so great to see everyone here tonight. It's wonderful to have our panelists and see some new friends and indeed a couple old ones on Zoom. Hi, Mina. It's good to see you again.
You as well.
And tonight, I'm going to serve as a moderator, but hopefully this is largely kind of an informative session for everyone to find out what it's like to be a doctor, what it's like, what sort of different careers there are that you could do with medicine or a medical degree. So we could just go down the line. Carl, if you'd like to.
So I'm Carl Bates. I'm originally from Central Ohio, went to Otterbein, graduated in 86, and then went to OSU for med school, did my pediatrics residency there, did my fellowship in nephrology in Dallas, Texas, moved back to Columbus where I worked for a number of years, then Pittsburgh in 2009, where I was the division chief of pediatric nephrology and the vice chair of basic research, and was there till I retired about 2.5 years ago, still in Pittsburgh. And so if you told me that I was going to be a pediatric nephrologist when I went to medical school, I said, what is that? I didn't know what that was. So, and if you said that I was going to be doing only a little bit of patient care and a lot of research and administrative things, teaching, mentoring, the same thing, I wouldn't have known that that was my career trajectory. But the sort of the point of this is when you hear the term doctor, that can be many, many different things, whether it's academia, private practice, specialty, generalists, doing research, teaching, administrative, or mostly patient care. So with that, I'll pass it on to my colleague.
Hey, everyone. Thanks for being here. My name is Seth Holtz-Saffel. I graduated a year after Carl. So we were pals and classmates back in the day. I'm from 1987. I did a little different path than probably my colleagues did. I didn't go to medical school right out of Otterbein. I graduated 87, worked for 2 years in a hospital here, and then took the MCATs a little later. I think somebody here had a question about when should you take the MCATs. My answer is don't do what I did. But anyway, I took the MCATs and went to med school in 1990 at Wright State University. Came back here to do my residency in internal medicine at Riverside. Some people may not know what internal medicine really even means, and because there's family practice when you're a general practitioner, there's family practice and internal medicine. And what I kind of say is family practice does both pediatrics and adult medicine, and internists only do adult medicine. And all of the specialties that you think of, like cardiology or pulmonology. They all went through an internal medicine residency first, and then you go and study whatever field you choose to. I was very close to doing gastroenterology. I had my applications and everything set, ready to go. And then I kind of decided I'm done. I didn't want to keep studying or do any more residency, so I opted to do general internal medicine. And I'm happy to be here and hope can answer some questions and help tonight.
Hi, I'm Mindy Finney, and I am an Otterbein alum, and I appear to be the oldest one up here. I graduated in 1985. I am from this area originally. In fact, I ended up coming to Otterbein because my father was a professor here in the life science department for 30 years. So it was sort of a natural transition for me. After my time at Otterbein, I did my medical school. At the time, it was called Medical College of Ohio in Toledo. It's now affiliated with the University of Toledo. It's their medical school. And after that, I went and did a internal medicine residency program in Akron, and subsequently went on and did a nephrology fellowship up at Case Western. I've been back in the Akron area since 1995. I started in my nephrology practice and just retired at the end of 2021. Had a very wonderful career there. I was also a faculty member at NeoMed, which is previously Neo-UCOM up in Rootstown. And I worked a lot with the students from there, taught at the medical school, also worked with them clinically on rounds in the hospital, both medical students and residents. We were a very large teaching hospital in the Akron area. Also involved a lot with administration. I was the section chief for nephrology there in Akron as well, and medical director at several different dialysis units, primarily in peritoneal dialysis and home hemodialysis.
Thanks, Mindy. Shannon, would you like to introduce yourself?
Sure. Can you hear me okay?
We're going to turn it up just a little bit, but I think we can, yes.
All right. My name is Shannon Miller. I graduated Otterbein in 1988. Was very close with Carl and Seth in the same fraternity. And graduated in 88. I took an Air Force scholarship for college and med school. So I went to Otterbein, and then I went on to Ohio State Medical School, and then went on to serve in the Air Force wherever they wanted me to go. My specialty is psychiatry and addiction medicine. I had no clue I was going to go into that field. I wanted to go into surgery. But, you know, through experiences in medical school and so forth, it took me a different direction. I've never looked back. I've been very, very happy with those choices. I served at the Andrews Air Force Base in Washington, D.C. That's a presidential Air Force base. When I got there, when I interviewed, it was all general psychiatry, which is what I thought I would be doing. But when I got there, it was all addiction medicine. And so I had to learn very quickly, and really fell in love with the field. And from there, I went on to Wright-Patterson Air Force Base, which, you know, I did med school at Ohio State, and I did residency at Wright-Pat Air Force Base and Wright State University. So I got an opportunity to come back to Wright State and the base there as an attending. And then I got out of the Air Force in active duty in 2004 after 12 years. And then I went on to looked in a lot of different opportunities, private, so forth, but ended up with the Dayton VA Medical Center for a couple of years, and then got recruited down to the Cincinnati VA for another 12 years. And in that time, I then picked up my reservist duty and finished with 20 years, retired in 2013. And then about 5-6 years ago, I went from the Cincinnati VA back to the Dayton VA, but this time to the Middletown community-based outpatient clinic, which is more of a rural type setting, something I'd never done before. And I've been there since. I live in Cincinnati, and I commute up there, and enjoy it very much. I've been active clinically and also administratively. I ran about a 70-person shop at the Tri-Service Addiction Recovery Center in DC, and a very large addiction service line at the Cincinnati VA. I've led education and training for couple different med schools with activities. Been active with research. I've been involved with the American Society of Addiction Medicine quite a bit with their textbook and their medical journal and conferences and so forth. So I've dabbled in a variety of different things. I always come back to Otterbein for a homecoming. I enjoy it very much. And it's fun seeing some of these old faces again.
Thanks very much. Mina, would you like to go ahead and introduce yourself?
Yes, thank you. Well, first of all, I want to thank Dr. Bates and the organizers and everybody for the opportunity to be here. Really honored and always happy to be back in Otterbein. What a wonderful place. Dr. Tanzi was actually one of my professors in college, so it's great to see you as well, sir. So I graduated in 2009. I did my training all in Ohio. So I did medical school at Ohio State. And then I did internship in Mount Carmel, and then I did a residency at Ohio State in diagnostic radiology. And then I did additional residency in interventional radiology. So I've had multiple areas of training, and I really love my job. I love radiology because it's at the forefront of technology and patient care, and we get to not only diagnose disease, but have the privilege and honor of taking care of patients and having impact. I love the problem solving that we have in medicine, and especially in my specialty, because we treat patients who are acute and sick and outpatients and different acuity levels and complicated issues. And a lot of times referring physicians come to us with questions and we get to problem solve together. So I love that about that collaboration. I think, one of the biggest things that hopefully we'll get to talk about today is just the opportunity to, help some of you guys answer questions about how to choose what career and that kind of thing. And I'm excited to be part of this panel. So if any questions, and I'm happy to answer hopefully through the discussion.
Thanks very much. So there are a lot of different ways we can go with this, but I guess I thought one thing we could do to start with for people is try to define some terms. So we've talked about the clinic, we've talked about administration, teaching, research. Do we want to define some of those? What does administration look like for you, or what have you done during your career? More specifically, how have you spent your time?
Yeah, so I was probably different than many people in the room. I knew I wanted to do research as a major part of my career. I didn't really know. I even thought about PhD. I actually thought about quitting medical school and getting a PhD, but some dean at Ohio State convinced me to stick around and stick it out for medicine. And it was, the struggle for me was trying to figure out what do I want to do in terms of research that would align with my clinical mission. And it just ended up being nephrology, something about the kidney that I even thought about doing internal medicine and nephrology at Riverside or something. So the kidney is a fascinating organ. It controls so many different things. If you're a numbers person, if you like to look at numbers, sodium, potassium, and something, and try to figure out why is this wrong? What's going wrong with this patient? It's a very cognitive subspecialty. It's not one that you use your hands a lot. It's a supratentorial specialty, I would say, right, Mindy? So there was that and the research. And along the way, I started writing some grants and getting some success. And all of a sudden, I started getting calls from places. You want to be a division chief? I'm like, oh, I don't really want to do. I love my research. I want to stick with that. But what happens is if you are, so MD clinician scientists are a real special breed. There aren't very many people. There aren't many people that do that anywhere in the world except North America. Because in Europe, the PhDs are primarily the ones that get research grants and do research. But the team that we ended up working with, it was a really nice dynamic team. They were MDs and PhDs, and they really contributed a lot. The PhDs are really smart people. They know their science, they know their research methods, but they don't always know the real clinical conundra. What are the unanswered questions that we still don't know about today? Why do posterior urethral valves happen in kids causing renal failure, leading cause of renal failure? Where do those come from? Many other clinical questions that I kind of bilingual. I spoke the clinical E's and the research E's and was able to bridge that gap. And you end up being, there were only 10 at the time. I got my first R01, which is the big NIH grant, 10 R01 funded pediatric nephrologists in the United States, and I was one of the 10. So put me on a list where all of a sudden I'm getting called from places like Yale, and I interviewed a couple of times, and then Pittsburgh, where the division chiefs were all also NIH-funded researchers. And as much as I love my research and being, you know, the first person to learn about how specific molecules were important in forming a kidney, that was really cool to learn those things. As I became a division chief, it became more about teaching and administration. So what does administration mean? Administration is being a leader, right? Leading a division, and I ended up my last 5-6 years, I was a vice chair for basic research. So now I spend much of my time not only focused on my own research program, but mentoring people throughout the department at the University of Pittsburgh, as well as nationally to Society of Pediatric Research. So what I ended up doing was I had no idea when I went to medical school where I was going to end up. But those are that in academia you can do research, you can do teaching, and you can do administrative work. So those are some of the examples that I had. I'll let my colleagues speak a little more.
Well, I'm a general practitioner for the most part, internal medicine. All I really do is see patients. I was on the board. I'm a part of a large group here in Central Ohio called Central Ohio Primary Care. We're actually the largest physician-owned group in the country now. Each physician has a share, so we're not controlled by any hospital or insurance industry or anything else. So that's great to have that kind of autonomy. And for a while, I was on the board, and certainly that had some administrative duties, but 90% of my time is direct patient care. For a while, I was an associate professor at OSU taking medical students, but that was some time ago, and I really haven't done that much lately. But I am interested in anyone that would want to shadow or come to my office. So we can talk about that and have some of those opportunities.
And I was going to take it back a step or two, because I know a lot of you are in the process of trying to decide what you want to do with this career. And what my advice to you would be primarily is to just take it one step at a time. I know a lot of people have a vision of what they want to be or what they want to do. It's like, I want to be this. And things change along the way. Before you become whatever it is you're going to become, it's going to be 8, 10, 12 years before that you're going to have to put in the work. I, like Carl, never would have thought I would have been a nephrologist. It's something I despised in my medical school training. Renal physiology just went right over my head. And so when you don't understand something, you don't care to do it. I knew I wanted to work with patients. I'm more of a people person than research-oriented person. And it's interesting that Carl mentions you like numbers, because had I not been a physician, I probably would have been an accountant. I absolutely love balancing things. I still to this day will balance my checkbook to the penny, just because things have to add up and equal. That's the same thing that happens in the body, both in kidney physiology, pulmonary physiology, all of it has to work out. So when you're looking at your future career, take the MCATs when you're ready. I mean, don't feel that you have to do it right out of graduating college. When you feel prepared to do it, that's when you should do it. Similarly, if you have something else you'd like to do between college and medical school, or if you don't get into medical school the first time that you apply, but you still have that desire to do it, do something that builds your resume, that is going to make you look like you're a well-rounded person. Be as active as you can in as many activities as you're able to do while you're here. This is a wonderful place to get experience socially, academically, and just being involved is what they're going to be looking for. Volunteerism is an important thing as well. We see that and we encourage that in both in the college realm, also in medical school realm and beyond. So all of those things are kind of where you want to focus your attention now, looking to your ultimate goal, but working through it one step at a time.
Shannon, do you want to go ahead and?
Sure. As far as administration, I think the first thing you want to do, you know, when you embark upon a medical career is be a very good clinician, be a solid, excellent clinician, know how to take care of your patients, number one. Number two, be a good teacher. That may mean that you have trainees with you, medical students or residents, or you may not. And that can mean fellow staff, non-physicians working with you. You have a much better office environment, a better flow if everybody understands the biology behind the illnesses that your patients are coming through the clinic for. They have an understanding of why certain things need to get done. You have much better of a team approach, and you'll be happier if you're a good clinician who's a good teacher. Thirdly, if you really want to expand your impact beyond the patient-to-patient level, maybe at the clinic level or division level, administration is an opportunity where you can marry up not only authority, but responsibility. Be careful in your career not to be put in situations where you have responsibility, but you don't have authority. That's a slippery slope that happens a lot. They want to give docs certain responsibilities, but they'll have somebody else make decisions about how that clinic is run or staffing and so forth. So when you have an opportunity through administration to marry that up, where you have a slice of maybe 20% of what you do isn't clinical, it's running a clinic and including helping to manage staff. The nice thing is that you much more easily can have the clinic run the way you want it to, because you're the clinical director, or you're the medical director, or what have you. Generally, when you do that, you get paid a little extra. Sometimes it's a little extra. Sometimes it's substantial, depending upon where you're working and what you're doing. The money can be nice, but I think more important is, do you really enjoy it? Do you really like the platform beyond your patients to make your clinic better, be in charge of a slice of the pie for the hospital or what have you? Fourthly is research. If you really enjoy exploring questions, and you can do that in a parallel path as you grow that in your career. But administration is a real opportunity to impact beyond your patients. But I think you never want to forget being a good clinician first and a good teacher. That's what I would offer.
Thanks very much. Mina, would you like to go ahead?
Sure. So several of my colleagues here on the panel have made really strong points about what type of career you guys could have. And I think the bottom line is that medicine is a very good career where you have a lot of options, and you can pretty much model what type of job you want in most specialties, I think, based on what you want to do. So traditionally, there's academics and there's private practice. And academics are jobs where you work associated with a university or some teaching institution. You get to teach, you get to often do research, and you still see patients. Private practice is more, clinically oriented, more, mostly taking care of patients, but there is hybrids, and there are situations where you could still have leadership or administrative roles, kind of managing the practice, building service lines, growing, as my colleagues have mentioned, and that can happen both in academics and private practice. So I think all the details at this year stage, are not necessarily like, I wouldn't worry about them, but I think what you should think about is that if medicine is something that you're interested in, you can pretty much find opportunities that meet your interests and find the job that, helps you, grow as a clinician, take care of patients, but also have the other interests that you have, whether it's doing research or and maybe leadership roles or teaching, if that's something you're passionate about.
Thanks very much.
So we have a surprise guest today, another ex-fraternity brother who went into medicine, actually started as a nurse, right, Vic? So this is Vic Triunfo, so we'll let him tell you about his story.
Well, thank you very much. What a pleasure it is to come back to Otterbein. First of all, I didn't know that the point existed. A patient of Seth's sent me a note and said that he was speaking tonight. And I opened up the brochure that most of you had received as well. And I saw his picture and I kind of said, oh, okay, I'll run into Seth. And then I looked and I actually know everyone except for Dr. McCary and Shannon Miller and the other, and Dr. Finney's father was my professor and was instrumental in me coming to Otterbein. So my story was a little bit different. I didn't come here until I was 22 27 years old, perhaps, when I came to Otterbein. So I enrolled as an evening student and then a daytime student. So I went to both night class and evening class because I was a paramedic, and then I became a LPN and then an RN, and then I came here and went to medical school at Ohio University. Relative to administration, I spent the last 15 years of my life as a hospital administrator. So I was the chief medical officer, which is the person that people hate the most. The doctors don't like them, and the administrators don't think that you're really an administrator because you're a doctor. So I lived in this no man's land for some 15 years. Basically, what I did in that position, though, it was almost all administration. I dealt with lawyers, contracts. I kept the electricity on at the hospital. All the regulatory rules that are associated with running a hospital is what I did for the last 15. Before that, I was an emergency room doctor. What a pleasure to be here. Thank you so much for asking me to join. I came just because I'm going to convince these guys all and ladies all to go for a drink afterwards. But Westerville is dry. Is it still, or is it things have changed? You fixed that. They fixed that apparently while I was gone. Yeah, well, thank you.
So, hold on. So how have things changed throughout your career? And I mean, people have had different careers. Some people's careers are kind of have transitioned into a retirement phase. Some people are still in the heart of their career. How do you view things broadly as having shifted over time? And that for each of you and how you've practiced medicine or how you've been involved in medicine.
Well, when I started out, you wrote your notes on a piece of paper. There were no computer. I mean, they had computers at most. I think you checked labs on computers. That was about it. So probably the biggest change was the electronic medical record, where suddenly and where it went from writing on a piece of paper to, so you got to learn computer and typing skills. For me, is in terms of my career change, I was very, like I said, I knew I wanted to do something with research. I didn't know what and what area and what specialty. And when I finally settled on that, that's where I thought I was going to live. So I think the change for me was learning how to be a leader, how to become a division chief. What does that mean? And what I learned is that when you take these positions, it has to be about the people that you are leading. It's servant leadership. It's you put them in front of yourself. And I found I really liked that. And then I went from that to just the division itself. Well, that was kind of fun too. I actually grew a division. We had 3 people when I started. We grew it to 9 or 10 by the time I finished. In fact, when I quit, I said I want to walk away, and nobody realized. It took some like a couple of weeks before they realized I'm gone. So fortunately, things have done really well. They're still doing well in that division. But then the change for me was then thinking about becoming a vice chair. All of a sudden, my portfolio is much bigger. Now I've got 50, 60 people, including PhDs, young PhDs that are trying to live in a clinical department and get grants and find their way through. How are they really full-fledged faculty members? Are they not? So I found myself advocating for them. So, the clinical side just kept shrinking and shrinking and shrinking for me. So by the end, I was only about 10% of my time doing clinical work, and the rest was really focusing on my and other people's research. So I think others can talk more about how medicine itself, the practice of medicine, has changed over time.
I can remember about 30 years ago when I was right out of my residency and walking into an office for the first time, wondering how am I going to do this and how can I see this many patients and how can I keep track of all this stuff? And as Carl said, everything was written on paper. I mean, you could certainly dictate and have someone type it for you, but it was all paper charts. We've been through probably 3 or 4 different electronic medical record systems, and every single one of them sucks, including the one we all use now called Epic. So learn Epic. But the other thing that I think is a big change in medicine is the payers and just the insurance industry and working with insurers and Medicare. Luckily, I don't have to do a lot of that, but you know, you think about it in the back of your head every time you order a lab or you order a test, and Epic tells you this isn't covered, or you got to do something else, or, and some of that kind of thing is challenging. Also, now the insurance industry is really looking at your notes, and that's another downfall of Epic, and the electronic medical record, because I can remember getting notes from my nephrology colleagues or my gastroenterology colleagues, and they'd be very concise, and you could read it, you could find out absolutely what's going on, and now you get 10 pages of crap that you can't figure out what the people even are doing or want to do. But it's all part of the game, and I hate to use the word game, but it is kind of part of the game. You have to have all your bullet points in there, and you have to have everything to get your codes and get everything right for billing purposes. And that's the aspect of medicine that I like the least. I like to talk to people. I like to take care of people. I like to joke with my patients, and you know, going to the doctor is not that much fun. So try to make them have a laugh and just at ease. But then, you know, when you're done, you have to sit there and chart on this patient, and it's the charting. It's the electronic medical records that really make it, in my opinion, the most challenging. I've still got a few more years in me. Hopefully I'll figure it out by then.
Yeah, I agree. When I first started back, back in the Stone Ages, I was very active with teaching. I was thrilled to do that. I loved that part of it. It makes you a better person, because a better practitioner, because you need to be on top of things, because you guys are right at the forefront of what's going on, and you ask us questions and we're like, ooh, I should probably know that. So it really was not only beneficial for me trying to teach you what I know, but the reverse of people teaching me what they know, or forcing me to find that out. So I was prepared. Early on in my career, similar, we were all on paper, dictation. Felt like we could spend so much more time with patients, which is what I wanted to do. I wanted to get to know them. I wanted to get to know their families, and have a long time relationship with them. As time went on and different constraints, both through insurance companies, bureaucracies, some things that were improved for medical training. There's some specific criteria now for how many patients a resident can see in a day's time, how many hours they're allowed to work. And this all came out of some legal issues, which in the long run are probably for the better. It makes it very difficult to teach, because there's so limited amounts of time that residents or students are available to us. And for me, that was somewhat disheartening. And so I kind of dialed back from that and just really focused on my practice. And again, the electronic records, they're so impersonal. It was very difficult to, like in my old charts, I'd always write, you know, so-and-so is going to Jamaica for a week or whatever. So when I would see them the next time, I could say, oh, how was your trip to Jamaica? And now we've got these just charted check boxes and things like that. So that was very disheartening as well. Also, probably in a good way, there's medicine is very much more evidence-based now than what it was back in the day. We would do things based on what I used to call, it was the practice of medicine, or the art of medicine. You learned things, you learned how to sort through things. You were a detective. And now we don't do necessarily a great physical exam. We might not say, oh, this person has an aortic stenosis murmur. Now we say, let's get an echocardiogram. And so the cost of medicine has gone up because of a lot of that. But if we don't do that, then we're at risk, because we're not using the latest technology. So that becomes more and more difficult to keep up with, particularly the farther along you get in your career, because you're just too busy with other things. And that's actually one of the things that kind of pushed me eventually into retiring, probably a little bit earlier than a lot of my colleagues. I was fortunate enough to be able to do so. But I wasn't being as fulfilled by the practice of medicine as I was when I started. That being said, you all are in this situation, you know what you're getting into. It hasn't changed. I don't think it's going to change that dramatically from what it did when we started to now.
I want to hear from Dr. McCary, because if I were to say that there was one area of medicine that has undergone the greatest transition, is as he mentioned earlier, he lives on the front edge of technology. When I first started, we took an X-ray and it came on a piece of film. and you would hold it up to the light, or you would hold it up to electronic board that had light on the back side of it. Dr. McCary now sits in his home. I haven't met Dr. McCary, but I'm going to tell you a couple of things about him. He's sitting in his home. He has 2 space age monitors in front of him, and he is reading films, or has the potential to read films, from all around the world. In Australia right now, someone twisted their ankle. Instead of but it's at 3 in the morning, right? In Australian time. I'm making that up. I don't know my time, but it's 3 in the morning. The radiologist is not in the hospital. They took the film and they sent it to America, and he's reading it and sending the report back. You want to tell us a little bit about telehealth services?
Yes, no, absolutely. You raised a few great points, and I agree with everyone else mentioned here. So first, very briefly, just about what my colleagues were saying here. The regulatory environment in medicine is always constantly evolving, and that adds pressures, whether it's reimbursement or rules or documentation, et cetera. But that shouldn't that's a challenge, but it's also an opportunity. So I don't want people to get discouraged by hearing these things, because every career you pursue has, positives and negatives, and it's something we learn to deal with, and we could use as an opportunity in the future as well. Going back to my colleague here, so about radiology, for example, radiology is one of the most evolving specialties, in my opinion, because of technology, as you mentioned. So in medicine, you can do teleradiology, where you can provide there's pros and cons to that, where you can provide imaging interpretation. So what we do is we read X-rays, MRIs, CAT scans, etc. But we're able to provide that to areas where there are no radiologists, in rural areas or other places, and we can help provide these services quickly, so that patients can get the answers they need. Because as we mentioned before, most patients that come to the hospital or anywhere, they almost often need some diagnostic test, and imaging in medicine is very important, because, you can feel somebody has abdominal pain, or can figure out they have abdominal pain, but you can also know 100%, is it a stone? Is it a tumor? Is it a clot? What is it? So I think having that diagnostic certainty is really, assurance is really helpful, and a lot of providers and physicians are ordering more imaging, and that's that. The other part for me is that I'm a diagnostic and interventional radiologist. So, I also use imaging to treat patients. So patients have bleeding, patients who have clot or different tumors, a variety of, like I said before, acute and subacute conditions. We can treat patients electively, patients in emergencies. So that's the beauty of medicine, and I think in my specialty, having that technology. But again, as one of my colleagues mentioned earlier, when you're, medicine is evidence-based, but not everything has also a cookbook, right? So part of being at the forefront of technology, when you're faced with new things, sometimes it's problems that people haven't faced before, or there's no studies or no randomized controlled trials, and you have to use your best judgment. So that's the beauty of being in medicine, where you have, to balance both the science of medicine, but also the art of medicine. And, and that's what keeps me personally going, because I really enjoy that, and having that relationship with my patients, and being creative. And, every day I get texts from oncologists, from primary care physicians, from OB-GYN, from other folks about patients, and we can problem solve. So hopefully that answers the question, but that's a good point. Thank you for raising that.
Thanks, Mina. Shannon, would you like to go ahead?
Sure. So some ways that medicine has changed. So I feel like I should give this speech that, back when I went to medical school, I had to walk uphill through the snow and this and that and the other thing. Mindy's right. GMA changes came along with rules, restrictions on training, which in the long run have been very good. I remember it was my internal medicine internship rotation, 2 months, November, December. I saw the light of day only on Sundays at about 5 o'clock, right before the sun went down. Never saw the light of day. We were in the hospital all day. It doesn't really happen that way anymore. Hours are much better protected, but you still work hard, and you should. But you'll enjoy it, because it's a great profession. You learn a lot of interesting things. You get to help people, as Seth was saying, tremendously. So the GME rules are one change. Another change, I think medicine's a lot more interdisciplinary than it used to be over the years. It used to be the doctor, whatever the doctor said was the way it was going to go. And mostly you saw the doctor and maybe in the nurse too, and that was about it. Now you have other professionals administering care. You have pharmacists who are giving some medicines directly. You have radiology technicians who can do some tobacco treatment therapies. It's a whole variety of things. And additionally, doctors nowadays typically more and more practice as a team with other disciplines on that team where you discuss patients and give different perspectives. So that's interesting. There's pluses and minuses with that, but that's another change. So you have to learn how to be a team player with that, but still be the lead since you have such extensive training and knowledge, but you're part of a team where they have their own expertise that they bring to the table. The next change I would say would be, I agree with Mindy, evidence-based medicine. I've had involvement with, when I was in DOD, with leading the DOD and the effort with the VA to create the first clinical practice guidelines for substance use disorders. Very evidence-based. It used to be medicine was practiced based upon what you learned in the books and how you applied it. But increasingly, it became more based upon cited studies, the quality of the studies, the level of evidence, and then rank ordering all of that together to form conclusions for each step in a decisional tree or a flowchart algorithm of how to make decisions. And we did that with the DOD VA clinical practice guidelines for substance use disorders. And then sometime after that, I got an opportunity to stand up the American Society of Addiction Medicine's peer-reviewed medical journal, Journal of Addiction Medicine. And there we really applied evidence-based medicine in terms of publishing it, but also in reviews and synopses in terms of how do you practice, how do you approach certain situations. So evidence-based medicine. And then I've gotten experience with ASAM, the American Society of Addiction Medicine, with their textbook. For the last 20 years, I've been an editor with that book where we apply that in terms of knowledge dissemination. And again, everything is based upon where the evidence is. I can tell you a number of times where I've had world experts with chapters who will write that chapter and we'll have the section editor review it, the associate editor review it, and then I review it as the senior editor, and I'll kick it back because I'll see conclusions as to, stimulants are a first-line medicine for adult ADHD, and I know that the evidence isn't quite there. And so we drill down on the evidence and see that these are studies that weren't really designed to look at the use of this medicine for this population. So we have to tether it back. So you as a physician, whether you get involved in administration, research, GME, or clinical care, always want to tether it with where the evidence is, and that protects you medical legally as well. So staying tight with clinical practice guidelines, up to date, other references that can guide you in your care is important, and I think very helpful. The last big change I would say is, and I would agree, is that of telemedicine. I'm a psychiatrist. I'm about 50-50 psychiatry and addiction medicine. Addiction medicine includes tobacco, vaping, and the case today of internet gaming disorder with Trevo or TiVo, where you shop online and you do video gaming. It's very strange. I learned about that. So, but I work 3 days a week from home. I see patients from home. When COVID hit, the VA was a very quick and early adopter of telemedicine. We were able to get iPads out to patients. 97% of my patient care visits during COVID were virtual. I saw very few patients in person. COVID has since calmed down. And we still maintain a posture of about 60% video because that's what patients want nowadays. They don't want to have to take the time to take the whole day off, come see you, wait around in your waiting room with a bunch of other people, and then go home. They like the opportunity to just step out of their workplace into their car in the parking lot, have their session with you for psychiatry anyway, where I don't have to poke and prod them with, and I can send them to the lab for certain things I need, but other than that, I don't have to necessarily lay hands on them. And if I do, I'd probably get sued. And so we do that, and patients really appreciate that. They enjoy the flexibility. I have patients I see in England, patients I see in all across the US as they move around in my clinic. So telemedicine is a very interesting area. There are now some boutique practices out there, such as Suboxone, buprenorphine for opioid addiction. There are clinics that are purely telemedicine nowadays that all of us at first thought, the old 80s term, gag me with a spoon. That's gross. You're not actually seeing the patient. But we've since learned, if they're done properly, these can be very effective modalities of care that really help people where they are, not just rural patients, but patients who are busy, patients who fight stigma and they're embarrassed to come into a mental health clinic. So telemedicine is another big, broad brushstroke, I think, that's been a positive change.
Yeah, I wanted to say in pediatric nephrology, telemedicine has taken a bigger role in part because there are only 450 of us in the United States practicing as pediatric nephrologists. In some countries, many fewer than that. So unlike adult nephrologists, where they're kind of a dime a dozen, you can find them in small rural communities. They're really only centered mostly primarily in academic centers. And some of these patients who live 4 or 5 hours away, it's much easier for me to engage with telemedicine as opposed to in person. One other thing I want to mention about evidence-based medicine, it's good, except it doesn't cover all aspects of medicine. Pediatric nephrology is not like many fields. It's a field of rare diseases. I mean, hypertension, kidney stones are leading to things, and from there, it's sometimes incredibly rare diseases, which actually kind of makes it kind of fun. Because there's still a lot of sleuthing that you have to do as a pediatric nephrologist. So if you're the type of person who likes to be, and that's another reason why I like to be a specialist, it would be hard for me to be a generalist and hear a murmur and wonder, is that a bad murmur? Is it a good, what is that? I want to know a ton about a really narrow area. I mean, I want to go deep into my knowledge. I want to be where the buck stops. And so that kid with blood in the urine, what does that mean? Is it bad? Is it good? What does it mean? When they come to me, we'll figure it out. So that's another difference between being a generalist. You see a lot of patients, a lot of different problems, but not as much depth. You come to see a specialist, we know a lot about a much narrower range. So you have to think about what you like. But anyway, we'll go on to the next.
Well, we've had another panelist join us. Dr. Jared Rohn is also here on Zoom. Dr. Rohn, can you hear us? Dr. Rohn's still getting logged in, I think. Well, actually, what we'll do, I actually wanted to circle back to something Shannon said, something several of you had alluded to is we're focused tonight on careers in medicine. Presumably you would have a DO or an MD to do that, but we've also now heard about several different ways other professions, pharmacy, other support services, PhDs in research have also contributed to your team or your field. Could we hear a little bit more about that? Who do you work with, for example, in administration? You know, how does that work across, you know, each of your careers?
So thank you. So in administration, then I had to deal with all the other subsets, right? So there are a large number, as was alluded to earlier, of health professionals across the board. Physical therapists, you can now go directly, if you injure your back, and see a physical therapist without ever seeing a doctor. And he can prescribe certain therapies for you. Pharmacy was discussed earlier. Pharmacists have expanded their breadth of practice such that they give immunizations in the office. They're able to perform and write certain medicines. A lot of that came about during COVID. Nurses, nurse practitioners, physician assistants, all these what are called allied legal professionals, ALPs, these folks all work in concert with the physician. If I could go off topic just for a second though. So if I'm you and I'm sitting there and I'm thinking to myself, okay, I came here tonight and all these old guys and young lady are here, but I need to get into medical school, right? So all this is great about picking a practice, but how do I get there? And perhaps in a moment, I was on the admission committee at Ohio State and at Ohio University. So I can give you a little insight later about sort of how it works to crack the nut, if you will, of getting it.
We definitely like to hear that.
Okay, yeah.
So, in addition to all the ancillary pharmacists, et cetera, particularly if you are involved with a chronic disease state, you'll often work with social workers, dietitians, there'll be nurses that work with you. And I can't tell you how valuable their input is for this, learning to work with that group of people because their connections, their insights, their resources that are available are not only helpful to your patients, but they're helpful to you in counseling your other patients. So like I worked with nurse practitioners, again in dialysis units with nurses and dialysis techs, social workers, dietitians, all have a multidisciplinary team taking care of each individual patient.
And then just in your office, you have your primary assistants and folks that help you and room your patients. And most of the time, a lot of times, they know the patients better than you do. I've had some of my medical assistants even go out socially with some of the patients. I don't know if that's good or not, but they are invaluable. In my building, we are lucky enough to have radiology. So we have radiology technicians that I deal with on a daily basis. We have a cardiology area where we have exercise physiologists and echo techs and that kind of stuff that you work with on a daily basis. So yeah, it's definitely a team approach.
Yeah, same thing for us, particularly in the, when Mindy mentioned chronic disease. You need lots of help with those patients. And I'd say the most would be our patients we consider for transplant. You'd have transplant committee meetings, which included reports from psychiatry or psychology, social work, the PharmDs. I mean, it was, in fact, the physician would be the first part, but they're only one member of the team. It was truly a team approach as it came to that. And if there were if there were objections that social work or psychology might raise about the status of a patient, we would put them on hold and not transplant them. So we did work with and valued the opinions of many of those other people.
Mina, would you like to add in?
Absolutely. Yeah, this is actually a very important point because, in school and undergrad and high school and all your training, a lot of times we're all focused on, getting the best grades and building ourselves and our experiences and more individualistic approach. And I think in medicine, once you go into medicine, and hopefully even before that, you're always a team player, but in medicine, it's all about the team, right? You can be the best doctor in the world, but your team has to have your back and you have to work from each other, together really well. And you learn from other people and other people teach you. And the best patient care is when everybody works at the top of their license, is how I call it. So, I work with nurses, with technologists, with other physicians, with pharmacists, with other radiologists, with all sorts of people. Some in medicine, some are medical, some are not. But every person is very valuable, and that's the key to success. So medicine is about interdisciplinary and multidisciplinary collaboration, and you'll get there, and that requires really good communication skills. Being able to communicate with others, negotiation, addressing conflict, all sorts of things, and sharing. So hopefully, as you go through your undergraduate career and beyond, you can focus on these things, and that's why they're important. That's why a lot of times when you're interviewing for medical school or other positions, they'll ask you, are you, they'll try to find out if you're a team player, if you have good communication skills, how do you address conflict, all sorts of things. And these are not just because, they want to, make sure they have a quote unquote nice person. Is because these are real life skills that help you, be the best person, best doctor, and the best team member you can be to help take care of your patient.
Shannon, would you like to add in?
I don't know if I have much to add. I think medical schools are more open nowadays to more wide-ranging interests of applicants, not just people interested in science and math and who do well in those areas. In fact, some are really trying to find folks that have more varied interests. certainly biomedical areas and medicine are very integrated with all the technology that's being built into medicine in terms of interventions and mechanisms of studying the patient. But ethics, there's a variety of other areas beyond science and math that they would have an interest in, provided that you've got that core coursework intact. I'm sure Vic could speak to that, what they're really looking for in a candidate.
So would you like to go ahead and tell us?
So I would say for those of you who are pursuing traditional, pursuing a traditional medical route. So we talk about medicine in general, right? So don't give up on being your life science majors. You can be pharmacists, you can be nurses, you can be physicians. But those of you who wish to go on to the physician route, I would say to you, it's very much a numbers game. So you have to really understand that process. So first of all, just like politicians, because we're in an election year, we have Democrats and Republicans. So in physicians, we have MDs and DOs. So those of you who perhaps aren't familiar with osteopathy, the largest medical school in Ohio is an osteopathic school. 50 students are up in Cleveland, 50 are here in Dublin, and 110 are at Ohio University in Athens. And that's where I'm a graduate of. And so that's actually the largest medical school in Ohio, and then Ohio State, Cleveland. So when you go to apply for medical schools, you want to apply a very broad number of schools, both in-state, out-of-state. Everybody has a dream school. For me, that was University of Pittsburgh. There was a guy doing studies. I was interested as a paramedic. He was freezing the brain of people who had heart attacks. He was putting, when they would do CPR, but they would also put an ice cap on the brain around them while they were doing their CPR in hopes to save cerebral. The brain is a high oxygen user, and so I was doing the work. So I wanted to go and study him. I didn't get in there. I got in at Wright State in Dayton. There's an interview you don't want to go. Don't stay in Fairbanks. The Air Force helicopters that Shannon and his group go over the cheap hotel that I stayed in all night long. And then I had to go for an interview the next morning. And Wright State at the time, I don't want to go too far off, had a walking machine. A professor there, and there was a movie about it. A lot of people there, because it's underground and it's northern Ohio, northwest, they get a lot of snow. So they built all these underground. So everybody in a wheelchair, student wheelchairs, are all there at that school. And so like I'm walking around and people are running over my toes with their wheelchair and so forth. So I go to the interview. But very much a numbers game. Apply for MD and DO. Learn about osteopathy, very similar, just like there's Democrats and Republicans. They're both politicians. There's physicians, MDs and DOs. I consider both of that. There's a lot of osteopathic schools recently. Some of them are good, some of them are not so good. MD schools tend to be associated with the larger medical universities. But here in Columbus, at Dublin Methodist, and 270, 50 medical students from Ohio University. But apply. Everybody wants to go, I'll just put this one, everybody wants to go on a mission trip because they think that's going to look good on their resume. Save your time and trouble. Most everybody has done that. Do something else, do something unique, and have that on your resume. But I'll just pass it on.
Would, I think we have a little bit more time left. Would anybody else like to add in anything about admissions or their process in getting into medical school? If not, I'd like to open it up for the students.
I'm happy to say something.
Please go ahead.
Thank you. So I was involved in screening applications for OSU as well in the past, and I have some insights on this. I think overall, and I'm not speaking for Ohio State, but in general, and I know this is like not secret information. I think all of you must have heard this, but we're looking for well-rounded people. So It's not necessarily, you have to be good in the sciences, but it's always good to show that, you have, community service, you have leadership skills, you have research experience, and then all the other things I mentioned. If you can get good letters demonstrating your activities, they're demonstrating you have good communication skills, you're a team player, you have leadership skills, you work well with others, you generally care about people and are compassionate or have, are in medicine for the right reasons. I think all these go the long way. So I think to have a good application in general is good scores, good, strong personal statement showing, why you want to do medicine, not just listing things, but maybe sharing a story or sharing your reasons or being insightful there, and a strong personal statement is really good. It makes us excited about reading the rest of your application. So, and I'm sure the rest of the panel can give insights on that. And then strong letters, and I would make sure that each letter emphasizes different part of your, so maybe one focuses on your academics, one focuses on your research, extracurriculars, different aspects of your application. So whoever is reviewing your application gets the full picture. And then the rest of the application will be about, all the things that you've done. And, when I look at applications personally, when I looked at applications in the past, I look at things experiences that show that you are definitely committed or interested, or, so if you show that there's a cause or something that you're interested in and you've been volunteering for a while, or if you're involved in research and, not just, you actually have a presentation or a publication or something showing that you have good work ethic and you endured with it. And research is about persistence and patience, and, were able to get something out of it, so things like that go a long way. And obviously, this is helpful for the application, but also for you to decide if medicine is right for you, because in healthcare, that you could be a physician, you could be a dentist, you could be a pharmacist, you could be a physical therapist. And I remember when I was an undergrad, I've shadowed in other areas. It wasn't always medicine. I wanted to make sure that it's a big commitment. So, but shadowing is very important, not just for your application to show that you have interest in medicine and maybe get a letter from somebody you shadowed, but also for you to see if this is the right fit for you. That's probably my advice for all of you guys.
Well, if we don't have anything else, if we'd like to hear from you, if there are questions that people have, we'd be happy to answer them. Who's got a question?
Hello, all. You guys did a wonderful job. Thanks for coming, by the way. I'm Destiny. I'm a pre-nursing student. So my question is more so for you to answer, but feel free to answer. What are some like non-clinical nursing jobs that you can say that you've worked with or seen?
Yes, so there's a great number of them. I worked with nurses who only did medical legal cases, so they reviewed cases for attorneys. I had nurses that were in medical sales, a very lucrative area. Pharmaceutical sales, another lucrative area. A lot of nurses were. I was a EMT first, and then a paramedic, and then an LPN, and then an RN, and then I went to Otterbein, and then I went to medical school. So I'm a very, I should have just done, and then I taught at OSU, but I should have stayed in education because I did it most of my life. But there are non-clinical positions, lots of them. Insurance companies, case review, quality, risk. I ran the quality and risk department at our hospital. My nurses wore nice dresses and hose and high heel shoes and long fingernails. Nurses that are on the floor don't do that. And these ladies worked Monday through Friday, didn't work nights, weekends, holidays, which the clinical nurses have to do. So there's a lot of non-medical positions in healthcare that are very important and need to be done, quality, risk in particular, but regulations, and you never sort of put on the white gloves and go in and see patients.
I could throw out a job I did at Otterbein. So the building, the dorm next to Hanby Hall, as you face Hanby Hall on the left, I don't know the name of it, used to be a nursing home, man nursing home. And I worked there in summers at Otterbein as a nurse's aide. I wiped bottoms, I changed diapers, I dealt with problems between patients. I had dementia, people that I took care of, I fed patients. And it really taught me, do I really have it in me to do this? Do I really care about patients? It helped me. I think it probably helped my application that I was able to demonstrate something that I did that showed I had my heart in the right place, and gave me an experience working around people and patients, that I could easily walk in and those jobs are available, and they really need people who really care and are good workers. So for me, that was what worked for me.
That nursing home is 25 Home. It's a dorm now.
What was it called?
It's a dorm. It's 25 Home Street.
25 Home Street. Okay. Yeah, I know. Yeah, that's what it used to be. No air conditioning there when we worked, by the way. Rough summers.
Is it air conditioned now? Not sure.
Hi, my name's Sydney, by the way. All of your journeys are so different and so unique. For any of us, do you have any advice if you could go back on your journey and you're like, what could I have done different, or what would I have left the same and not have changed anything?
I can start with that. I am very happy with the journey I took. And mine was fairly traditional. Um, uh, Undergraduate, medical school, residency, and blah, blah, blah. One of the things I would change about myself looking back is I would have been a much more open person and I know particularly a lot of the science people tend to be a little bit, I want to say introverted. Get yourself out there. I actually did not get into my first choice of medical schools or my second or my third because I couldn't interview. I couldn't speak to people. And so I would sit in an interview and I was just terrified. So it's important when you're interviewing for these things to be yourself, be open, ask questions, things like that. But the career path I took, I got there a roundabout way. As I said, I didn't ever think I would do nephrology. I thought I would do this, and I had a little bit of experience in it, didn't want to do it. You'll find your place. It'll come to you. The other thing I want to leave you with too is one of the most important things as you go forward, because medicine is a tough career. Whatever ancillary field or anything that you're in is going to be difficult. And it's really important to maintain a balance in your life between your practice, your professional life, your home life, your family life, and make time for yourself during all steps of this, whether it's in medical school, take some time away from studying. If it's in your residency, make sure you're getting some free time. When you're practicing in there, make sure you have time for yourself and your family.
Yeah, one thing I want to point out, you're never terminally differentiated. So what I'm saying is if you start going down a path and you decide it's not for you, then you can think of doing something else, right? I mean, I've seen people who have done that. People that wanted, there's actually a guy that I did my fellowship with. He was medicine, then he was med peds, then he did med peds nephrology. Then he decided to drop the adult nephrology, be a pediatric nephrologist. Then in the end, he worked in industry and dropped them all. So you're never, if you feel it's not right, if it's not working out the right way, you can take another direction. So just keep that in mind as well.
Would anyone on Zoom like to add in?
I agree with
Thinking- I think how do you take care of yourself is a good medical school admission question. For me, it was distance running. For other people, it's working out. For other people, they have a social club that they go to and enjoy. It's important for you today, but it's also helpful for you when you apply.
Yeah, I echo all that, and I have no regrets. I'm happy with the path I took. I think, I think one of the things you will learn, as you mentioned, is that everybody's path is different, and find what works for you. I think along the way, I would say enjoy the journey, right? So it's a long road, as one of the colleagues here mentioned, and you're going to be there for years. So you can't be stressed out the whole time. You can't, you have to find balance in your life. So enjoy the journey, but also, maintain all the other things that keep you, right? So if you like to draw, if you like to sing, if you like music, if you have hobbies, you're going to be under pressure because you have to study and you have exams and you have lots of things to do. And, that's part of life and part of medicine. You have to work on time management and prioritization and balance and all these things we talk about. So, don't lose your, don't forget to be you. So, and wellness is important. So, keep that in mind as you go through the journey.
Hello, my name is Jian. I'm a first year here, and I just wanted to ask a question. Right now, I'm interested in teaching, research, and working working in clinicals as a physician with patients. But I'm afraid finding a career that does all of this would take me far away from my family. I'm a very family oriented person, and I think I'm putting too much onto myself because I prefer teaching, researching, and clinical again. It's not like one or the other. I want to do all of them, but I'm afraid that's just going to take me away from my family life. And is there a career that helps me with that?
Well, so I have engaged in all of those things. What I can tell you in the end, you really can't serve all the masters equally. I mean, you're going to have to make a choice at some point in your life. For me, it's heretical for me to say, but I love my research. If you tell me I like clinical medicine here, research was here. You really can't serve two masters. I mean, if you want to do research, you got to be 70, 80% protected. What I mean by that is, when a patient calls and they have an acute emergency, you can't say, well, I have a Western blot to run. I can't address that. So the way you deal with that is you work, in our division, we had people that were 80, 90% clinical, and then we had people that were 80% research. So yes, you're right. If you try to do all those things, you won't have a life. I mean, you really can't, but you'll sort it out, right? You figure out what floats. And again, it can change. You can go into this saying, I really want to do research, right? I really want to do research. Then you write your first research grant and you keep getting told no and no and no. And after a while you say, I've had enough of this. I think I'll be a clinician. So yes, I mean, you will have to, at some point you'll figure it out, but even as I said, you're never fully pigeonholed into one thing. You can go back and go the opposite. I've even seen people that have been clinicians for a long time that say, I really want to try to write a K grant. Can you help me with that? And so I'd help mentor them and get them to write a K grant and start to get into research. So one other thing I just mentioned is, find mentors along the way. That is a really critical part that I didn't really pay much attention to. And I learned later in life was really important. So you see somebody that whether you're shadowing them or when you're in medical school, you see somebody that's maybe a nephrologist. I wonder what that's about. Let me have to talk to them. And they love to tell you about what they do, right? And you can tell everybody here loved what they did. So and there are different types of mentors. There's career mentors, there's work-life balance mentors, there are time management mentors. Just keep that in mind. And remember, they all put their pants on one leg at a time like you do. They're people. Don't be too intimidated. If you go people and approach them and you want to talk to them, they usually, even if they're introverts like me and Mindy are, they still want to tell you what they did because they like what they did. So just keep that in mind.
One other thing too, there are, in addition to research, I don't know what you want to call it, laboratory research, there's a lot of clinical research that goes on in medicine too. So that can combine some of your interest in clinical medicine with research, doing research projects on, disease management or things like that.
And just to add to that, I was a director of research for COPC, so it was like medical research with patients and different new drugs coming out. And so that's obviously not your research, but it's still something different.
Yeah, I would add that, I've never been more than 20% research time, but I've had an opportunity to be involved in a number of different projects and some publications. I would recommend running as a herd and not individually. So you're going to start as a clinician. It's pretty easy to find, to be associated with trainees who want to work with you, and there's some teaching. Maybe you teach a couple classes at the medical school. Find people who are doing research, find people who are writing the grants, find people who are successful with that, like Carl, and see if they need help with as a sub-investigator or maybe a co-investigator. somebody who's not necessarily writing the grants and so forth, which is a whole different talent and a lot of work, but somebody who needs somebody to be involved with the study, administer aspects of the study, and ideally have an opportunity to help write part of the paper. And that's how you get a feel for, is this something I really want to do, without making that full commitment and feeling overstretched. So it's a nice way to start. And if you really like it, then find that mentor, maybe somebody on that study, to grow that into more of, if you like research, into a research career. And I agree with Carl, a K award, or in the VA, Career Development Award, CDA, that's a mechanism that protects a lot of your time over a couple-year period, where the focus is training you in research so that you can be successful.
Absolutely. And just specifically on research, there are a lot of residencies, several residencies, at least in my specialty, have combined masters in research and residency in radiology, or even general surgery. For example, at Ohio State, the general surgery residents have a year of lab research. So that gives you those skill sets if you're interested. I think you could do it, depending on the amount of interest you have and your commitment, you can do an MD, PhD, be formally trained, be a clinician scientist, have your own lab, go full force in that. If you want to be primarily a clinician, and like Dr. Bates mentioned, you do have to negotiate time, because you're only one person, and you can't be the best clinician, researcher, teacher, and other things at the same time. So I think you, at any one time, maybe one is your focus, and you can still collaborate, as Dr. Shannon mentioned, and participate with others, and you create a team, so it's not all on you to do everything. And if you're working in a medical center, I think it's easier because, as he mentioned as well, you have residents and students interested in research. So, you can guide them, you can mentor them, and they can collect data, and then you come back and forth and you work as a team. And then maybe other colleagues who are more interested in the grants and the full aspect of it, you can collaborate. So a lot of science in medicine is not necessarily basic science. So there's basic science bench research, where you do experiments and all this stuff, and you try to translate that into the clinical world. But there's also clinical research where, I feel like the barrier to entry is a little bit easier, because you could do short reviews and do some retrospective studies and other types of research that is maybe not as high powered or as complicated, but you could still contribute to that if that's important to you. So I think, like everything else we said, depending on your passion and what you want to achieve in your career, you can customize your training and customize your jobs that you look for at some point to make it work. So don't let that be don't think that's going to be a challenge. I think if you do it right and you have the right mentors, you can make it work.
I think we have time for one more question.
Hi, I'm Keaton. I'm a fourth year student. And I'm just curious, what are some qualities of a good physician that you guys think are oftentimes overlooked?
What are qualities that are overlooked?
Great question. I would say being humble enough to understand that there was a time in which the doctor was superior, right? The doctor was the top of the pinnacle. That was, you had achieved the nirvana, if you will, right? That is no longer the case. I am humbled each day when I worked by the people that I worked with and what they brought to the table that was different than what my skill set was. And so I would say a certain humbleness, and mentioned earlier by Dr. Bates, was that servant leadership. That is really where it's at. That is spot on. But a slice of humble pie each morning when you wake up, when you're a physician, is not a bad way to start your day. Low in calories too.
I'd say the ability to empathize, not sympathize, but empathize, knowing what your patient is telling you, and feeling that. I agree with Victor. staying there and telling a patient, I'm going to prescribe this, do this, do this, do this. They're probably not going to do that. But if they sense that you know what they're telling you, I always tell my patients this, you usually tell me the diagnosis, not the other way around. So if you know what your patient is telling you, you empathize with your patient. I think that's that and the humble pie.
Would anyone on Zoom care to add in?
I'm
Go
happy to weigh in, or I'm sorry, go ahead, Dr. Miller.
Um, yeah, I would echo most of that. I think you have to be smart, you know, you have to know the field, know what you're studying. I think that attention to detail is important in your clinical care and your documentation. When you tell a patient you're going to do something, you need to do it. When you tell your fellow staff you're going to do something, you need to do it. But as well, empathy is tremendous. You have to really understand the plight of your patient and what they're going through and be able to communicate that to them, but also communicate it to fellow staff. I think that's very important as well. And the last thing I'll say is curiosity. Being a curious person, when you run across something you don't understand or you can't quite figure out with a patient, read. Demonstrate that you read. These qualities are qualities that I think medical schools look for, that you read up on it, that you learn more. That will serve you well in medicine. You will never know everything, and everything will always be changing on you. We're old. We know that. Things keep changing. If you don't keep reading, you stop learning. And so having that curiosity, I think, is very important.
So I concur, and I think, you know, hardworking, lifelong learning, as just Dr. Miller mentioned, team player, all this stuff, compassion. Obviously, if your heart is in the not in the right place, then none of this matters. But I think, you know, going back to your question, which is what is overlooked, I think being a good listener, I feel like sometimes because we're under pressure from regulatory and this and that and patient care, and patients are complex and limited time. And so, you know, I think listening is super important. You know, I think you learn a lot from your patients, but as was mentioned before in the panel, the patients will tell you. So I can't tell you how many patients I've seen that said, you're the first person that took the time, and, you know, and I'm not a genius, but I figured out what they have because the clues are there, and sometimes they will tell you what the issue is, but sometimes people are rushed and they don't listen enough. So I think listening goes a long way. You know, it's not like, you know, you're the doctor and you know everything and you're there to tell them what's going on. I think we often emphasize in medicine, you know, open-ended questions at the beginning. And I think that's very, very, very valuable. And I think it goes a long way. If you just wait and if you just give them a couple minutes and listen, and when somebody says like something, you just let them explain and you look at the clues, it goes a long way. So that's that's the one thing that I think is overlooked frequently, but goes a long way.
There was a study a couple of years ago that showed that physicians interrupted their patients within 18 seconds of them starting to tell their story. So imagine if you had a friend like that, right? You're talking to them on the phone and you're going to tell them about your day. And the first thing they do is tell you about their day or tell you about their thing. So 18 seconds before the physician interrupted the patient. And as Seth was saying, the patients tell you the diagnosis if you're listening, as Dr. McCary stated as well. So that good listening skill, very important.
Can I just add on, maintain a sense of open-mindedness, not only to your patients, but to events going on around, cultural differences in people. You need to be open-minded about what they're telling you, and open-minded with, as things are changing. Don't be stuck in, oh, this is how we did it. So you need to be open-minded and willing to experience change.
One last thing, don't forget to take care of yourself too. You know, I mean, it can take a lot out of you, right? This is a heavy commitment, whether you're, I mean, for me, it was fretting about the damn NIH and why are they rejecting my grant again? I mean, there's always, on the flip side, I love what I did. I love the research so much. So But you got to take care of yourself, you know? If you have to, if you put your heart and soul and everything into that research grant and you submit it and it comes back not funded, put it away in your drawer for 24 hours before you start looking at the comments. Get some ice cream, drink a beer, whatever it is you need to do to decompress. And you're going to have stressful moments. That's part of the job. And find a way to deal with that. You got to find a way to deal with that too. Just remember, you're human too.
Well, I'd like to thank everyone tonight. I'd like to especially thank our panelists. If we could have a round of quick applause for them. I think this has been a really wonderful evening, very informative and fantastic wisdom from everyone.
Thank you.
I'd like to turn it back to Dana.
Yes. This is working. Yes, thank you, Dr. Tansey, so much for moderating. And I want to thank Dr. Bates for helping to organize all of this. I know it took a lot of time and we just appreciate it. And thank you to our online Zoom physicians. Thank you all for being here. We appreciate it.